6 o'clock, the board members are here. Shall we go ahead and call this meeting to order? If you're able, please stand and join me in the Pledge of Allegiance. I pledge allegiance
to the flag
of the
of the United States of America
and to the
and to the
republic
republic for which it stands,
one
one
nation,
nation,
under God, indivisible.
indivisible, with liberty and justice for all.
Thank you very much. Dee, would you please call the roll?
Director Yee,
Present.
Director Stewart,
Present.
Director Wallace,
Present.
Director Eapen,
Present.
Director Nicholson.
Present.
Very good. And who else is in the room with you there?
We have Kimberly Hartz, Chris Henry, Tina Nunez, Larry Lavoisier, Paul Kozachenko, Shri Badu, and me, D'Antonio.
Okay, great. Thank you. Well, welcome to the August 10th, 2022 regular meeting of the Washington Township Healthcare District Board of Directors. To continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by the SARS-CoV-2 virus, the Brown Act allows a local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Health Care Services Public Health Department COVID-19 website at www.covid-19.acgov.org. I ask for a motion that the board make the finding required by section 54953E3 B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing.
Madam President, I make the motion that the board make the finding required by section 54953E3BII of the Government Code that state or local officials continue to impose or recommend measures to promote social distancing.
Thank you. Is there a second?
Second.
Thank you, Dr. Nicholson. Okay, roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Eapen,
Aye.
Director Nicholson.
Aye.
Very good. Thank you. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom, and I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Moving on to communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record and then proceed with your statement, not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Okay, none. Are there any written communications, Dee?
There are not.
Thank you. We will now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Hearing none, does any member of the public want to remove an agenda item from the consent calendar? All right, then may I have a motion to approve the consent calendar items A and B, please?
Dr. Stewart,
I'm
you're on
sorry.
mute.
I apologize. I move that the board of directors approve the consent calendar items A and B.
Very good, thank you. Is there a second?
Second.
Thank you, Dr. Nicholson. Roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Eapen,
Aye.
Director Nicholson.
Aye.
Very good, that passes. All right, now we get to the fun things. We have a presentation first. Kimberly, can you do the introductions?
Yes, thank you, Madam President. It's my pleasure this evening to introduce Joanne Pineda. She is with the American Heart Association, and she has been with them for over 10 years. And she has got some special presentations this evening. She is the Quality Improvement Manager and oversees quality, data, and outcomes research for the American Heart Association. And I know we also have some of our medical directors and others that are involved in both our stroke and STEMI programs here this evening, and maybe at the end they may want to say a few words. It's my pleasure to introduce Joanne Pineda.
Thank you. Is it possible for me to share my screen?
Yes, it is.
Okay, thank you. Do you see my screen okay?
Yes, we can.
Perfect. So good evening. My name is Joanne Pineda, and I am the Quality Improvement Manager with the American Heart Association. It is a privilege to be here today to honor your achievements and to celebrate with all of you. The American Heart Association, American Stroke Association is pleased to present Washington Hospital Healthcare System these awards for outstanding quality stroke and STEMI care delivered by your hospital to the citizens of your community. We congratulate all members of your clinical team and the magnificent work they do every day. Led by Dr. Rose, Dr. Kalsa, and Maria Nunes, your stroke team continues to exceed the bar of stroke care since joining Get With the Guidelines Stroke in 2006. The Get With the Guidelines Stroke Award recognizes hospitals that treat 85% of eligible stroke patients according to the AHA's recommended guidelines for 1 year. The Target Stroke Honor Roll Award is presented to a very exclusive group of hospitals, both in California and nationally, that treat at least 75% of their acute stroke patients in 60 minutes or less, providing the patient the opportunity to receive a clot-busting drug, which has been proven to improve outcomes for the stroke patient if given within a very short period of time after symptom recognition. The Target Diabetes Honor Roll aims to ensure that patients with type 2 diabetes receive the most up-to-date, evidence-based care when hospitalized with stroke. I congratulate your hospital for achieving the 2022 Get With the Guidelines Stroke Gold Plus, Target Stroke Elite Honor Roll, and Target Type 2 Diabetes Honor Roll. I am especially excited for Dr. Lin and the STEMI team this year. Like the stroke award criteria, if the Get With the Guidelines Coronary Artery Disease Mission Lifeline Award recognizes hospitals that treat 85% of eligible STEMI patients according to the AHA's recommended guidelines for 1 year. Since joining in 2020, the team was able to achieve their first ever award focused on STEMI care. I commend your hospital for your commitment in achieving the 2022 Mission Lifeline STEMI Receiving Silver Award. Adherence to both stroke and STEMI guidelines, adherence to both stroke and STEMI evidence-based guidelines saves lives and improves patient outcomes. But the guidelines emphasizes a multidisciplinary team approach to patient care. In addition to your champions I mentioned prior, I'd like to say thank you to additional members, your leadership team, Kimberly Hartz, Larry Labossiere, Brenda Brennan, Nicholas Legge, John Lee, other key members, Michael Platzbecker, Annalyn Cisneros, Sally Way, and of course, nursing staff, your ED staff, rehab, radiology, lab, the list goes on, for their hard work and dedication to improving the quality of care for patients. I'd also like to recognize your EMS colleagues as they are a key in the stroke heart attack system of care, and their pre-notification is a critical factor in achieving good patient outcomes and ultimately recognition from the Heart Association. As in prior years, the American Heart Association will celebrate your hospital and all silver and gold winning hospitals nationally with local and national recognition by our Heart Association with a listing on our website and inclusion in the July Healthcare edition of U.S. News and World Report, as well as recognition at our annual conferences, cardiology scientific sessions, and International Stroke Conference. It is my pleasure to present these awards to Washington Hospital Healthcare System for your outstanding commitment and dedication to quality stroke and cardiovascular care. Thank you for all that you do to save lives and improve outcomes for the patients and families that you are privileged to serve in your community. I'm grateful for the opportunity to support you in our shared mission and grateful to all of you. I look forward to our continued relationship and quality, and even expanding into other Heart Association initiatives, such as initiatives around community impact and health equity. Congratulations again.
Very good. Yay. Thank you, Joanne, for your presentation of these awards and for both acknowledging and affirming our staff and physicians who work hard every day taking care of our stroke and STEMI patients. We applaud them with you and hope that the residents who view this presentation will see the awards and understand the highest standard of care that we strive to achieve for them. Thank you so much.
Thank you.
Very good. That's very exciting. Congratulations, everybody.
And I just want to say thank you to the team. It truly takes a team to get the results that we have seen this evening. And we have many physicians and staff throughout the whole healthcare system that is integral to the success of these two programs. And I know I see Dr. Jack Rose, and I want to thank him as co-medical director of the stroke program, Dr. Carmen Akawili as medical director of the intensivist program and ICU, CCU, and with medical staff, Dr. Hyder as chief of staff, and many others that are probably on that I unfortunately am not able to see. But I know Maria Nunes and others have really played an important role, and we're really here for the community. The work that this team does is always thinks about what is best for our patients and our community. And I want to thank all of you and for what you do for our patients. So thank you.
Congratulations. Very good. Well, let's go ahead and move on to reports. We have our medical staff report with Dr. Hyder. Good evening.
Hi, good evening to all. Thank you so much. There is a leadership development committee is being formed under the chairmanship for Dr. Prasad Kilaru and the medical staff. Hope everybody will be represented, especially from the women's side. Women representatives should be there adequately. And also the medical staff fully support the effort of administration and especially Ms. Hart's effort for personal to support our trauma center and emergency room, and also to have new technology and new machines upgraded. And we are modifying the COVID policies after a long time, and we are moving with this is the time we have to do it because of the changing times. And also, we are in the process of hiring a vascular surgeon for WTMF. Presently, we have locums who are doing the coverage. In fact, we are going to look for another surgeon too. The top hat is being organized this year after a gap, and this money will help for the new cancer center. And our medical staff role is the grand total is 579, active members are 339, allied health 36, ambulatory 96, consulting 8, courtesy is 26, leave of absence is 4, provisional active is 48, provisional AHP is 9, provisional consulting is 2, and provisional courtesy is 10, and the relinquishment is 1, so the grand total is 579. And there was recently circular from Dr. Levin regarding their testing from Arup laboratories for the monkeypox, to test that. We have the ability to do that, and it will take about more than 2 days to get result for that. This is my report.
Okay. Thank you very much, Dr. Hyder.
Thank you.
All right, Service League report from Debbie Ferry, our fearless president.
Well, good evening, members of the board, and greetings from the volunteers. The month of July, the Service League volunteers contributed 1,765 hours to the hospital. During the month, 128 volunteers staffed their assignments. Also in July, we saw a huge increase in the number of COVID-19 test kits requested by the lab. And in June, in June, we assembled 350 kits. And in July, the number was up to 2,075. So this increase obviously coincides with the current surge that we're all living through. And it has actually hit home here. My youngest son is on Paxlovid right now. He has COVID. So, so yes, I'm a mom and very worried. For the hospital's fiscal year that ended in June, the volunteers staffed 16,219 hours, which I'm really proud of, because given how long the program was shut down for the pandemic. So for the fiscal year of the hospital, we did have a nice impact. I just want to highlight that we continue to welcome back our junior volunteers, which are our high schoolers. And we now have 25 high school volunteers, and they're staffing the lobbies and the gift shop. And the interest in our orientation has been very strong. In fact, we're having one on the 20th of this month, another orientation. And as more areas open up, we will resume there with the high schoolers and the rest of the staff that we can get.
Yeah.
And that's my report for the month.
Great. Thank you, Debbie.
Thanks.
Stay well.
Thank you.
Yeah, been there, done that. Wonderful. We have a lean report. Kimberly, will you do the honors of the introduction, please?
Yes, thank you. This evening, it's my pleasure to introduce Gulnaz Hanif. She's an RN and has been with our infection prevention program as the manager at Washington for more than a year. Prior to her current role, she worked in various positions over 20 years, including working as an infection preventionist nurse for over 5 years with the Palo Alto Medical Foundation in Palo Alto. She holds a Master of Science in Advanced Public Health Nursing and with the focus in Community and Public Health and Health Policy from the University of California, San Francisco. Today, she will be presenting on lean initiatives and its impact and their impact on healthcare-associated infections. So, welcome, Gulnaz.
Thank you, Kimberly. Thanks. Good evening, everyone. I will share my slides and we'll go from there. I hope you guys can see the video as well. Please let me know if you guys can see my screen.
Yes.
Yes, we can see it.
Excellent. Okay, so let's see here. Okay, so basically today, good evening, everyone. Thanks for having me. So I'll start off talking about applying lean principles to patient care. Basically, I'm gonna introduce catheter-associated UTI, which is basically called CAUTI, and you'll see me use the word CAUTI throughout this presentation, which is CAUTI is basically catheter-associated urinary tract infection. It's an infection of urinary tract caused by a tube, which is a urinary catheter that has been in place to drain urine from the bladder. Among UTIs acquired in the hospital, approximately 75% are associated with urinary catheter. Between 15 to 25% of hospitalized patients receive urinary catheters during their hospital stay. Therefore, catheters should only be used for appropriate indications and should be removed as soon as they are no longer needed. CODI can lead to complications, and few examples that I'll share with you today is prostatitis or otitis in males, and pyelonephritis, gram-negative bacteremia, sepsis in patients. Complications associated with CODI cause discomfort to patients, prolonged hospital stay, increased cost and mortality rates. It has been estimated that each year more than 13,000 deaths are associated with UTIs in US alone. So this particular slide is basically an example of a process board which includes 3 sections. And you can see each section is basically, the first one is understanding the goal, which is all in green. So I'm going to give a very brief overview. And then as you can see in orange, it's understanding the current state, and then implementing improvements is in blue. So the process board basically ensures that team goals support vision and facilitates root cause analysis. Our team meets at the process board every Tuesday with our CEO, which is Kimberly, our lean team, and other interdisciplinary as well, including quality team as well. So the purpose is to focus on the process and make it easy to compare expected outcomes versus actual performance. So as you can see, where it says understanding the goal, the division goal, which I'm going to talk about today, is basically decrease baseline CODI, standardized infection ratio, which is known as SIR, from 3.14 to 0.72 by June 30th, 2022, which is fiscal year 2022. And of course, I'll focus on the key drivers, the plan, obstacles, and current projects as we move through the slides. So here's the background. Basically, the background, as you can see, our hospital initiatives are to reduce hospital-acquired infections, and there are many that we focus on, but today our focus will be catheter-associated UTI. So for the division goals, I'm going to go into discussing our division goals, which is our aim is zero harm, basically. And the goal is to decrease baseline CODI to below national standard and decrease the number of Foley catheter days. The key drivers is basically reducing Foley catheter days, which will lead to less CODI events. And how will we get there? So we have to adhere to all the components of the CODI bundle, ensure all Foley catheters have appropriate clinical indications, implement nurse-driven Foley removal protocol, ensure optimal catheter care during the entire hospitalization. And of course, collaboration between interdisciplinary teams and different units to help facilitate best practices. So this next slide basically is the zero harm improvement journey, and it's sort of the lean process. As you can see, we have started with identifying the key obstacles. As you can see, the obstacles that we found, basically nurse-physician engagement gaps, nursing empowerment for early catheter removal. And based off those, not necessarily only 2 obstacles, there were many others. There was a CODI task force initiated, and their focus was to basically drive focus on CODI bundle rounds and nurse-driven protocol, which is basically implementing it, updating it, working with the urology team, and coming together and making sure that we have a protocol that can empower nurses. And then, of course, utilize unit-based daily management system to act on bundle round foundings and communicate effectively. Establish visual management practices to build awareness and focus. Then from there, basically spreading the best practice. Whatever is captured in the bundle round foundings, we utilize that by having the nursing educators spread best practice across units as well. Other areas that we've looked at is systemize standard work that's working with EPIC team to address standardization and eliminate manual data collection. Of course, better utilize EPIC's reporting capabilities as well. Some new innovations that we have implemented is basically use of external catheters and straight catheter applications, which is very short term. and of course, align practices with HAI reimbursement requirements. To sustain gains, again, we want to continuously utilize DMS and visual management to monitor progress and identify further opportunities for improvement, which will, of course, make zero harm possible with respect to our process that we have placed, allowing patient dignity and safety as well. So this next slide basically is, I wanted to show you what we have in place for our use here at Washington Hospital. This is a urine catheter Foley tray system. As you can see on this catheter, there is a stop label or a stop sign, which allows the end user to think and to stop and critically think prior to using a catheter and determine the reason why it is needed. And the reasons are listed on the label. So therefore, if it doesn't meet criteria, then they get a chance to collaborate with their providers. This particular slide basically is an example of urine catheter Foley tray components. I wanted to share with you what we do, and it is all part of the CORI bundle. As you can see, A stands for always clean the patient. Before even cleaning the patient, we advocate for hand hygiene prior to patient care. And always clean the patient. We have a peri-care kit where you would clean the patient prior to Foley insertion. And of course, you do your hand hygiene. And B stands for be sure to use aseptic technique. So we have this tray labeled as such that it's step 1, step 2, and step 3. So everybody is following the same process throughout to ensure standardization. So there is no risk for cross-contamination. And then when a person is moving from one area to another, we always, of course, encourage hand hygiene if there is any risk of cross-contamination. Care and maintenance, as you can see, we advocate for making sure that the catheter tube is secure, maintain a closed drainage system, and then bag below the bladder at all times, which is part of the CORI bundle. This is an example of a tool to monitor catheter placement. Basically, we look for types of Foley and indications for Foley and determine if there is any fallouts, and we do real-time education on the floor as well. So this one right here is basically fiscal year 2021 and fiscal year 2022 monthly CORI trends and intervention timeline. As you can see, the bars in red represent number of CORIs, and the line in yellow represent the number of urine catheter days. As you can see, there is a trend line which is in green. It shows a very steady decrease over time. And then the squares, the first blue square, as you can see, this is when the CORI task force was initiated, which was around April of 2021, which is Q2 of 2021. And then in Q3 of 2021, nurse-driven Foley protocol was implemented with the help of the nurses here at Washington. And there was a lot of nursing education that went through with that as well. And in Q2 of 2022, IP team unit rounding for bundle compliance began. Prior to beginning the bundle compliance, our team rounded with the lean team, that's Cheryl and of course the CNOs, Tigas, to help us understand the why and how can we help the units determine if there is any opportunities for improvement and if there is any fallouts. So those are the things that we looked for before rounding. So that way, when we are rounding, we are looking for things that can help us understand what's going on. This is basically for SIR, which is a standardized infection ratio for CORI. This is for fiscal year 2021 and 2022. As you can see, in fiscal year 2021, we've had 22 CORIs with a SIR of 3.31, which is pretty high. And you can see in fiscal year 2022, we had a total of 7 CORIs. So there was a significant improvement and a significant decrease in CORI. Again, the SIR was 1.13. We would like to see the SIR to be below 1. But we, again, we hope that we will continue to decrease and sustain the CORI events over time, less CORI events over time. This is basically what I'm showing over here is the number of catheter days for fiscal year 2021 and fiscal year 2022. and it shows standardized utilization ratio. Again, our goal is to decrease the number of Foley catheter days. As you can see, for fiscal year 2021, it was 8,366 with a SUR, which is SUR of 0.62. And then in fiscal year 2022, we had the number of catheter days was 7,819 with an SUR of 0.5. So we are doing well, and we hope that we can sustain. Anything below 1 is great, but we are at 0.5, so which is excellent. So we hope to sustain. Lessons learned and next steps. Basically, the goal is to stop and critically think the need for Foley and if alternatives can be the option. We encourage managers to share weekly report with staff to create awareness around the healthcare associated infections. That's the SIR and the SIR. Work with nursing and EPIC team to standardize the HAI bundle components to increase automation, so it is less labor intensive and there is less room for error. Of course, we want to prevent barriers to protocol implementation and provide ongoing staff education through huddles, unit-based meetings, and unit rounds. Also, reducing Foley days alone is not enough to significantly impact the reduction of SIR. Use of CODI bundle reinforcement and monitor compliance for sustainability is crucial. Some things to consider when evaluating increase in catheter days include high patient census, clinical indication for Foley, complex comorbidities, use of nurse-driven Foley protocol, also assessing if we have new or float staff that need training or competency, taking into account short staffing, perineal care, and use of external catheter options, etc. Something to consider: timely and early urine collection, and also considering other etiologies or looking for other reasons for UTI. The other last but not least, it's important to have ongoing leadership, physician team, and all staff support and engagement. And I want to thank Lean team and quality team and also the leadership team for making it all possible. So this is all I have. Thank you for having me. And if anyone has any questions, I'm happy to take questions or comments. Thank you.
Thank you, Gulnaz.
Welcome.
Keep up the good work.
Thanks.
Any questions from other board members?
That's very, very impressive.
Thank you. Thanks. I know it was a lot of information. Thanks.
We appreciate that. Thank you. Thank you. Okay, then we can move on with our quality report, Kimberly, if you want to.
Yes, this evening is Mary Boron is here. She's the Chief of Quality and Resource Management, and she's going to present the quality dashboard for the quarter ending June 2022, and also giving an overview of how we did in fiscal year 22 compared to goal and last fiscal year. So I'm going to turn it over to Mary.
Great, thank you, Kimberly. Yes, so I'll start off with going through each section with the quarter ending data. And as Kimberly mentioned, we think that since this is closing out fiscal year 2022, it's also a great opportunity to kind of just look back and say, how well did we do on an annualization of these metrics? So after I present the quarterly ones, we'll go ahead and do the annualization. So starting off with infection prevention, this was a great quarter for infection prevention. With our first one, hospital-acquired MRSA in the blood, which is a pathogen that is very difficult to treat with antibiotics, very resistant to treatment in general of even strong antibiotics. We have 0 observed infections, and so therefore we met our goal on MRSA. For catheter-associated urinary tract infections, I obviously won't spend much time on this because you just heard from Gulnaz about all the work they're doing and the success they've had. That's continued to reflect in this last quarter where we did have 1 county, and I think, as I mentioned, there's enough background to understand how we'll continue to work on that. But the key point is it's just right about being slightly lower than what was predicted. For central line associated bloodstream infections, otherwise known as CLABSI, we did have one CLABSI this quarter. It is lower than what's expected. The CDC and HSN expected us to have closer to 2 infections. The predicted is statistically 1.7, but this is a good accomplishment. We're continuing to focus on this to make sure that we don't even have one. And we're doing bundle compliance and monitoring all patients who are at risk for CLABSI daily. And when we do have one, a CLABSI, we're doing a root cause analysis. Moving into our surgical site infections, starting off with colon surgeries, which can be high risk for patients getting infected. We've continued to see a great deal of success at that. Our 4th quarter without any SSIs related to our colon surgeries. And this is basically right around where they would predict we should be at. Same with abdominal surgeries that are specific to hysterectomies. You can see that we've had 6 quarters in a row being at 0, so a great outcome for our abdominal hysterectomy procedures. C. diff is also a spore that is very difficult to treat with antibiotics, and it's something that we've really been focusing on preventing over the last couple of years, put a lot of efforts into this, and we're definitely in a sustaining phase of keeping our C. diff cases far below the number that they would expect for an organization of our size and type. We did have 2 hospital-associated C. diffs. The CDC expected us to have closer to 9, so you can see that that's a significantly lower amount, which is great news, considering that we're going on our 6th quarter with having far less than expected. It's really important that we keep with our initiatives around appropriate testing and treatment and early isolation for these patients. Hand hygiene, this is across all departments and is done by a multidisciplinary team who does these direct observations. We are at 88% for this quarter. That does get us above the World Health Organization goal, which is 70%. The Joint Commission would like to see us closer to 90. Altogether in the organization, we want to see this at 100% because we do not want to be seeing obviously any failed opportunities for hand hygiene. So we're continuing to work on that, training more observers. It's also really important that when these observations are done, that we speak with the staff and anybody who's been observed as missing an opportunity for hand hygiene, so we can learn from whatever experiences that they're having, such as making sure that our hand hygiene products are readily available, people are not interrupted in the middle of doing their care, and that they understand how our observations work. So that will continue to be a focus, obviously, through fiscal year 2023. So this is the first example of sort of pausing after infection control and looking back on the year and saying, okay, how did we do? We bring this forward quarterly in this setting, and it's nice just to sort of summarize everything for the year. So altogether, out of all the areas of this section, we did meet for 4 out of our 7 HAI goals reduction, meaning that we exceeded it with green, with our CLABSIs, with our colon and our SSI surgeries, and as I mentioned before, a lot of success around C. diff. We did see a significant amount of improvement around MRSA. It didn't get quite to where our goal was. It was just slightly over it, but you can see there's a big amount of improvement when you go from 2.7 cases at our baseline to down to less than 1. So MRSA has actually quite a bit of success, as does the catheter-associated urinary tract infections that you heard Gulnaz speak about. We didn't get quite to our goal, but again, drastically reduced from 3.4. And as I mentioned prior, we'll continue to work on our hand hygiene efforts moving into this fiscal year. Our next section on nurse-sensitive indicators, starting off with our falls per 1,000 patient days. For this quarter, we did have significantly lower falls than expected. I think this is a great reflection of nursing staff and all the disciplines actually rounding not passing call lights, making sure that fall risks are assessed, that patients are safe even when left sitting up. We like to get these patients up and get them ambulated. It's so much better for their overall health. And we want to keep them moving and trying to use the bathroom on their own as much as possible. But if you're at a fall risk, it's something we have to put a lot of effort in to make sure that they are safe while doing all those activities. And this really reflects an outcome of a safe environment for patients at high risk for fall. The same applies with our hospital-acquired pressure ulcers. Our rate for this quarter is 1.15, and it's less than the national rate of 2.2, significantly less. This is a reflection of patients getting really appropriate care on being turned when they can't turn on their own, making correct mattress choices for patients who are at risk for having skin breakdown. It's even a reflection of proper food and nutrition when patients are able to take in their own food and nutrition. This is really important on making sure that they don't have skin breakdown. It's also important to point out that we do assess this right on admission because we like to know the baseline that the patient has for their skin. So if this is a hospital acquired, so any ulcer that developed after the admission would be captured in here. Our annualization is great for these two metrics. Again, we did meet out of 2 of the goals per year. As you can see, both are in the green. So great success, especially reflective of a magnet hospital. Moving into our readmission rates, this tends to be the most challenging area of our quarterly report. Starting off with heart attacks, otherwise known as AMIs. We did have 6 patients come back out of 30 patients who were potential for high-risk readmissions. And this does put us above our national benchmark. The CMS would expect us to be closer at 15.8%, and we were at 20%. These patients had the average age of about 80 for risk for readmission of the ones that did come back, the 6. And they are complex patients with end-stage renal failure. We had some cardiac dysrhythmias that we wanted to admit the patient for to continue to monitor closely, and they needed interventions on an inpatient stay. So I think the 6 cases are indicative of patients that absolutely needed to be admitted, have chronic illness, and are high risk for readmissions. Pneumonia is an area that we have had a lot of challenges with, and this quarter is good in the fact that we've actually seen a decrease in pneumonia. We had 10 patients who were readmitted, putting us at a rate of 14.1, which meets and exceeds the goal of the CMS benchmark of 16.7. So that's a good outcome for those high-risk patients. Heart failure continues to be a challenge. We had 21 patients return within 30 days out of the 85 patients that have potential for a return, putting us at a readmission rate of 24.7. CMS expected us to be closer to about 22%. So this case, we look at all these cases, they go through a high risk working group, and we look back to say, what could we have done maybe to prevent these? The average age of these patients collectively was 79. They did come back for reasons that sometimes were related to their heart failure. And then of course we had cases that were completely separate from their heart failure. It'll be key for us to continue focusing on assessing these high-risk patients the day they're admitted, setting up transitional care plans, really working on care coordination. And we're meeting daily in multidisciplinary rounds. And we also have a group that even drills down further on these high-risk populations to identify what needs they have around pharmacy, family help at home, home health, SNF, et cetera. So again, a complex population that we continue to work with. COPD, otherwise known as chronic obstructive pulmonary disease. For this quarter, we did have 5 patients returning. And that put us at 27.8, again, higher than the CMS benchmark of close to 20%. The same thing really applies with these patients. They are obviously chronically ill. We do absolutely admit patients who need acute care, regardless of any penalties from CMS. If a patient comes here and is sick and needs inpatient care, we absolutely make that the top priority to give them. And in these cases, I think that was the case with these 5 patients. And we'll continue to focus on the same thing, trying to prevent the readmission so the patient doesn't have to come and be in the hospital unless they absolutely need to be. And that would be around looking at their pharmaceutical needs, transport needs, getting to their doctor's appointments, things like that continue to be very similar to our other high-risk populations. Coronary artery bypass graft. These are patients who have CABGs, and we've always had a lot of success with this patient population. We did have 2 come back this quarter and be readmitted, but that put us at 10.5, which is lower than CMS benchmark of 12.6. I think moving on to our hip and knee replacements, we did have a blurb for a couple quarters where we had just 1 patient come back, and we look like now at this point we're at our first quarter in the last 3 where we have 0 patients. And again, you can see from prior quarters it was unusual to even have 1 readmission in a quarter. So we're hoping that this will sustain. So out of 16 of those procedures, 0 came back. So closing out our readmissions annualization, as I said, this is the most challenging area that we're dealing with. We did meet 2 out of the 6 readmission goals, and we did see significant improvement with pneumonia, bringing it down from 29% on our baseline to 22.4. We didn't make it to what we wanted to, which was the 15%, but again, improvement, and with our surgeries, great readmission outcomes with those. But as you can see, really where we need to focus on is these chronically ill patients with very complicated disease states, elderly, around COPD, heart failure, and AMIs. And I think a lot of the work we're doing around improving care coordination and setting up a great transitional care program will help us get closer to these goals moving into fiscal year 2023. Thank you. Any questions?
Thank you, Mary. Any other comments from board members? I'll keep up the good work. We set that bar so high, but it's great. Okay, thank you. We'll move on now with our finance report from Mr. Henry.
Okay, thanks, Director Yee. Tonight we'll be looking at Washington Hospital's operating and financial results for June 2022, the last month of fiscal year 22. We'll start with our acute inpatient statistics. Inpatient average daily census was up by 7.5 patients at 154.4. When we add in our outpatient observation days, which are patients that are in a bed but not considered inpatients, we come up with a combined average daily census that's 10.3 higher than the budget at 164.1. Admissions were 41 below budget at 809, but patient days were 226 higher than budget at 4,633. Outpatient observation equivalent days for June came in 85 higher than budget at 291. And our average length of stay for the month was higher than budget at 6. We'd expected 5.18 days. Moving into our utilization statistics. Case mix index for the month was lower than budget at 1.598, so the cases were a little bit less in severity than we had expected. Deliveries for the month came up 8 above the budget at 119. We'd expected 111. Surgical cases for the month were 23 higher than budget at 361. But our cath lab cases were 36 lower than budget at 188 for the month. Outpatient visits for June were 391 visits higher than budget at 7,556. and the emergency room was much busier than anticipated. They saw 842 visits more than we expected, to 4,735. Looking at the detail in the OR and the cath lab, really the surgical case volume driven largely by our joint replacement cases, which were 33 higher than the budget. Those were offset by cardiac surgical cases and our general surgery and other cases that combined were 13 below budget. Our neurosurgical cases were 3 higher than budget for the month. In the cath lab, that variance of 36 cases lower than we expected. Again, the big driver there was our cardiac cases in the cath lab. They were lower than budget by 48. And again, physician turnover in the cath lab has given us some challenges with volume, but we do have some new physicians coming on, and we expect to start to see those improve. Looking at productivity, productive FTEs for the month were 51.3, higher than the budget at 1,348.7. We had 243.4 non-productive FTEs, and 39.9 of those were related to the special COVID sick leave that was mandated by the state, and that is unaccrued, so it comes right into FTEs and salaries. So we ended the month with total FTEs that were 111.3 higher than the budget at 1,592.1. However, our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in 0.92 lower than budget at 5.88. Moving into financials. First, we'll look at our Governmental Accounting Standards Board presentation. This is the presentation that we use for our audited financials. Total patient revenue for the month came in just under $4 million higher than budget at $181,333,000. Our deductions from revenue for the month came in just a hair lower than budget at 77.51%. Moving into the details of that, our contractual allowances, which include Medicare and Medi-Cal and commercial insurance payers, came in a little bit lower than budget due to a favorable payer mix at 75.14% of gross revenue. We'd expect at 75.68%. However, our provision for bad debt and charity came in higher than budget at 2.37%. We'd expect a 1.88%. Private pay was higher in the payer mix this month. However, those offset each other, and we come in again with our total deductions from revenue really close to budget at $140,546,000 or 77.51%. Moving into our expenses, operating expenses, we're pretty close to budget, about $51,000 favorable, but we had a lot of things going on in there for the month. Salaries and wages with our higher FTEs were about $1.5 million higher than budget. Our benefits offset that. They were about $1.5 million lower than budget, and that included health and welfare claims that were about $570,000 lower than budget. And we received our post-retirement medical benefit actuarial report in June. And we saw about $1 million pickup from that as our liability reduced due to, similar to the pension plan, the assets in the pension plan and the investments performed pretty well. Supplies for the month were $673,000 higher than budget. That was driven by prosthesis with our higher level of joint replacement cases. Reagents were higher than budget. We had a higher level of COVID testing in the month. We saw an inflated level there. And then our PP&E continues to be over budget. We're still having issues with supply chain and keeping those prices up. Purchase services for the month were down about $357,000 from budget. We have, as you recall, we had an agreement with some of the local SNFs to reserve beds for us to keep moving patients along. We let those contracts lapse and renegotiated those deals. And as a result, we were able to drop our standing accrual on those about $400,000. In our insurance, utilities, another category, that was down $637,000. Insurance, professional liability insurance came in about $120,000 lower than budget. Our electrical bill came in $137,000 lower than expected. We did expect a big spike in electricity during the year that did not materialize. Marketing was lower than budget by about $62,000 due to timing, and our shared savings program is coming in lower than expected this year. So we ended up June with an operating bottom line of $1,061,000 against a budgeted loss of $195,000. Non-operating income for the month came in with a loss of a little bit over $1.1 million, that largely driven by an unrealized loss on our investments of $994,000 as interest rates continue to rise. The yield on our investments, or at least the value on them, reduces. So we end the month with a total bottom line for June of about a $42,000 loss, pretty close to break even. We'd expected a $107,000 loss for the month, but we end the year with a nice, really a nice performance with a year-to-date operating bottom line of almost $28 million. We had budgeted $269,000 for the year, and a total bottom line of just under $20 million, and against a budget of just about $2.1 million. So really a good year financially for the healthcare system. Moving to our Financial Accounting Standards Board presentation, and this includes, as you know, adjustments that the financial markets might make to our financials when they look at us. First thing they do is they reclassify our revenue bond interest expense out of the non-operating category. They believe it belongs in the operating category to give us an operating bottom line from a FASB perspective of $485,000. The next thing they do is they don't recognize our general obligation bond interest or the tax revenue that supports those payments. They also don't recognize our unrealized gains or losses on investments, so that comes out. So we end up with non-operating income for the month from a FASB perspective of $227,000 and a total bottom line of $712,000 against a budgeted loss of $392,000. Taking a look at EBITDA, our earnings before interest, taxes, depreciation, and amortization. This is a representation, gives us an idea of how much income our operations and non-operating activities generated from a cash point of view. First thing we do is we pull out depreciation because that's a non-cash entry. And we end up with operating expenses excluding depreciation of $36,262,000 and EBITDA, earnings before interest, taxes, depreciation, and amortization of a little bit over $5.1 million. The next thing we do is we look at our non-operating income before our interest expense, and we end up with a number of $674,000 from that point of view. So in total, Washington Hospital's operating and non-operating activities for the month of June generated about $5.8 million for our debt service, capital expenditures, and program development. So pretty good month for the month of June from an EBITDA standpoint. So are there any questions on June?
Oh.
Okay.
Thank you very much.
All right, so I will move forward with the fiscal year 23, the first month, July of 2022. And you'll see that we had another busy month, and that really focused on a lot of the medical patients that we saw. So gross revenue of $189.8 million for July was above budget by $2.8 million or 1.5%, and was above July of 2021 by $4.7 million or 2.6%. Our inpatient gross revenue of $117.3 million was above budget by $7.1 million or 6.4%, and $8.4 million or 7.7% above July of 2021. Room and board revenue was higher than budget by $4.1 million, and ancillary revenue was higher than budget by $2.2 million. And lastly, surgery revenue was higher than budget by $1.4 million. Cath lab revenue was below budget by $1.2 million. Looking at outpatient gross revenue of $72.4 million was below budget by $4.3 million or 5.6%, and $3.7 million or 4.8% below July of 2021. And outpatient surgery revenue was lower than budget by $3.4 million, and cath lab revenue was also lower than budget by $1.8 million. Also want to recognize in July, we had 116 COVID-19 discharges, representing 14% of our total discharges. And this is an increase of 30 cases or 35% from the prior month, which was 96 more than June 2021 at 20 total discharges. So I think we all realized that both June and July, we had a higher number of COVID patients. Moving on to our key census statistics, the average length of stay of 5.49 was below the budget of 5.51 by 0.02 or 0.4%, and above July of 2021 of 4.85 by 0.64 or 13.2%. There were 10 discharges with length of stay greater than 30 days, ranging from 34 to 64 days, and if you excluded these 10 discharges, our average length of stay would be 5.02. Still in-house, at the end of the month, we had 10 inpatients with length of stay over 30 days. We still have a couple of very high, they range from 34 to 299 days. The average length of stay for the 116 COVID-19 patients discharged in July was 5.85 days, which is lower than in prior months. So those who are COVID inpatients, we are not seeing them as sick as we've seen in previous months, or their acuity is not as high. Outpatient observation days at 287 was below the budget of 290 by 3 days, and 57 days below July of 2021. Our inpatient daily census of 160.1 was above the budget of 140.6 by 19.5 or 13.9%, and above the July of 2021 average daily census of 134.8 by 25.3 or 18.8%. If you look at the combined average daily census of 169.4, it was above the budget of 149.9 by 13% and 16.1% above the July of 2021 average daily census. And if you remember, the combined average daily census includes the observation days. Moving on to our admissions, admissions of 853 were above the budget of 791 by 62 or 7.8%. July 2022 admissions were 42 or 5.2% above July of 2021. Also, in terms of patient day trends, we also saw an increase of that were above budget. Our patient days of 4,963 were above the budget by 605 or 13.9%, and were 783 days or 18.7% above the July of 2021. We did see a slower surgical trend. So if you look at our total surgeries in July of 341, they were below budget by 24 or 6.6%, and surgeries were 50 or 12.8% below July of 2021. Inpatient surgeries at 149 were 12% above budget, consistent with July of 2021. Outpatient surgeries at 192 were 40 or 17.2% below budget and 20.7% below of July of 2021. Looking at the breakdown of the surgical activity, our joint replacement surgical cases were below budget by 12 or 7.9% and were 19 or 12% below July of 2021. Neurosurgical cases were below budget by 2 or 7.1%, but were 1 or 4% above July of 2021. Cardiac surgical cases were below budget by 5 or 38.5% and were 8 or 50% below July of 2021. And lastly, all other surgical cases combined were below budget by 5 or 2.9% and 24 or 12.5% below July of 2021. And really this decrease and then the slower month for surgeries was really related to a number of our physicians being out, whether mainly in terms of vacations for the month. And so that is really what brought down our surgeries for July. We're also seeing some challenges in the volume for the cath lab, and again, we did have some physicians that were out or we're still recruiting to, and we'll touch on that. The cath lab cases for July at 180 were 40 or 18.2% below the budget of 220, but 1 or 0.6% below July of 2021. Cath lab inpatient cases at 94 were 16.8% below budget, but 13.3% higher than July of 2021. And cath lab outpatient cases at 86 were 19.6% below budget and 10.4% lower than July of 2021. Then looking at that, the cath lab activity broken down, you can see that cardiac cases were below budget by 21 or 20.8% and 12 or 13% below July of 2021. Also, non-vascular interventional radiology cases were below budget by 14 or 21.2%, but 10 or 23.8% above July of 2021. Peripheral vascular cases were below budget by 4, 8.7%, but 2 or 5% above July of 2021. And then lastly, our neurointerventional radiology cases were lower than budget by 1 or 14.3%, but 1 above 20% above July of 2021. So really, again, a great deal of the cath lab volume and the decrease that we saw. We do have we've been recruiting for a vascular surgeon who will be starting at the end of August, and so that was part of what was driving some of the reduction in the cath lab. Also, we had one of our interventional radiology physicians, our IR physicians, that was out for the month of July too. So really our volume was greatly impacted by physicians being out or still some of our recruitment. Moving on to deliveries, our deliveries for July of 138 were above budget by 14 or 11.3%, and 12 or 9.5% above July of 2021. Looking at our non-ER outpatient trend, or our non-emergency outpatient visits of 7,299 were below budget by 514 or 6.6%, and were below July of 2021 by 9 or 0.1%. The majority of this was we did have, in terms of from our outpatient imaging visits, we did have a piece of our equipment that was down for 4 days, and so that greatly impacted our mammo was down for 4 days, and so that greatly impacted our outpatient visits in that area. Moving on to emergency room, as you can see, our emergency room continues to be very busy. We saw visits of 4,799, which were above budget by 268 or 5.9%, and 365 or 8.2% above the prior year. Looking at our gross revenue, patient days, as mentioned, were above budget by 605, As a result, our room and board revenue was also above budget by $4.1 million or 12%. Our emergency visits were above budget by 268 or 5.9%, driving emergency room revenue up by $498,000 or 4.2%. Deliveries were above budget by 14 or 11.3%, increasing revenue by $248,000 or 7.1%. Surgical cases were below budget by 24 or 6.6%, driving $2 million less in revenue than budgeted for surgical services. Cath lab cases were below budget by 40 or 18.2%, resulting in $3 million less revenue than budgeted. And then lastly, ancillary services were higher than budget by $2.8 million or 3.2% due to the increase in inpatient activity. Moving on to our preliminary payer mix, which was very much challenged during the month of July. As you can see, our government-sponsored patient revenue made up 74.1% of total gross revenue. This is higher than the budget of 71.4% and higher than the prior year's percentage of 71.6%. HMO was 2.1% of gross revenue, below the budget of 2.6% and lower than the prior year's percentage of 2.2% of gross revenue. PPO was 22.7% of gross revenue, which was below the budget of 24.4% and lower than the prior year's percentage of 23.7%. Lastly, our private pay was 1.1% of gross revenue, which was below the budget of 1.6% and lower than the prior percentage of 2.5% of gross revenue. Moving on to our productivity indicators, our productive FTEs were above budget by 27.7 or 2.1% at 1,351.5. Non-productive FTEs were above budget by 19.5 or 8.5% at 249.9. And total FTEs of 1,601.4 were above budget by 47.2 or 3%. Looking at our productive FTEs per adjusted occupied bed was 5.22, which was lower than the budget of 5.55 by 5.9% or 0.33 and lower than the prior year of 5.4 by 3.3%. Our total FTEs per adjused occupied bed of 6.18 were lower than the budget of 6.52 by 5.2% and lower than the prior year of 6.38 by 3.1%. So in terms of that, we're in line with and better than some of our budget. I do want to mention we had the non-productive variance was primarily due to employees on COVID sick leave. We did struggle with both staff and physicians out on COVID, but for the staff, we had 36.8 FTEs that were on COVID sick leave during the month of July. So still seeing a high number of staff that were out with COVID. Looking at our preliminary outpatient statistics, our Medical Foundation clinic visits were above budget in July by 1,829 or 12%. At 17,017 and were 1,081 visits above July of 2021. And really we saw many of the areas above budget, including primary care, ortho, urology, pediatrics, and Warm Springs. Looking at our Development Corporation outpatient visits of 1,871, they were below budget by 308 or 14.1% for July and 10.9% below July of 2021. A great deal of being below budget was through Washington Outpatient Rehab Center. They were below by 293 or 22.1%. They really had a great deal of staffing issues during the month of July, and we had staff out on maternity and also had a couple of staff that have left, but now we are filling those positions. Also, Washington Radiation Oncology Center treatments were above budget by 11.7%. Also below budget, Washington Outpatient Surgery Center was below budget by 58 or 11.6%. And we did have, again, that was impacted due to physician time off. The Peninsula Surgery Center was down 17 or 56.7%. And as you know, we recently did an open house. However, we are still waiting for our Medicare certification number. So we are only limited to certain types of patients. We cannot do our commercial payer patients at this time. So we are still waiting. We have already been accredited, so we are just basically waiting the formality of getting this number. And many of the other surgery centers are also struggling with the same thing and waiting too. So. And then lastly, Ohlone College Student Health Center, the visits were up 23 or 209%. Moving on to our key financial statistics, our days cash on hand for July ended at 158 days. It was a decrease of 9 days from last month, and this really was primarily due to the repayment of the revenue bond debt service principal and interest made on July 1st, and this was $11.5 million, and this was basically accounted for these 9 days. And this is the largest payment that we have to make on our bond debt service per year. So we often see this in July. Looking at our days in accounts receivable as of July 31st, they were 64.4. This was impacted by a number of factors. First, Blue Shield closed their offices for the entire week of July 4th for the holidays, so that slowed down payments. Also had the month ending on a Sunday. We also, this department was very much impacted by COVID and had a number of staff that were out for COVID sick leave. And then lastly, there were $283,000 in charity care adjustments for July. And so that is the report for the first month of the new fiscal year.
Very good. Thank you, Kimberly. Any questions for her? All right, then do you have any announcements for us?
I do have a couple of announcements, and I'm going to start with our Employee of the Month for August, and that is Raymond Tam, and he's a physical therapy aide. According to August Employee of the Month, Raymond Tan, his work environment with supportive and very dedicated coworkers makes coming to work at Washington Hospital a joy each day. As an aide to physical, occupational, and speech therapists, Raymond has the opportunity to work with patients who cannot move well on their own due to illness, wounds, COVID, or post-surgery. These patients must work hard to rebuild strength or learn new ways to move, and Raymond finds joy in seeing their progress each and every day. At Washington Hospital, Raymond had found supportive mentors and coworkers. He was hired by Jenki Wu, who encouraged him on a regular basis. Though Jenki succumbed to cancer, Raymond still thinks of her leadership and feels he would not be this month's Employee of the Month without her initial belief in him. Additionally, he recognizes Director of Rehabilitation Services, Christy Casey, for her leadership and support. Christy is not surprised by Raymond's desire to make this award about others. Quote, he is the type of employee that will always do more for others than he expects of them. Quote, she notes, he embodies the patient-first ethic. Raymond's role also has a critical administrative side. He orders supplies, schedules patients' appointments, and is willing to provide coverage for various roles. He works well to anticipate the needs of the therapist and plans ahead. His extraordinary attention to detail is an asset to the department, and his calm, generous demeanor is appreciated by both coworkers and by patients. Inspired by his work with physical therapists, Raymond has a goal of returning to school to complete coursework to become a physical therapy assistant and eventually a physical therapist. Congratulations to our August Employee of the Month, Raymond Tam.
Very good.
Yes.
Good for him. Good for him. Great. As there does not seem to be a need for a closed session and there being no further business, this meeting can
I
be
have a
adjourned.
couple of quick, just Jeannie, it's okay, I was gonna say, I have a few other announcements, sorry, I should have
Oh, I'm
gone
sorry.
straight into those.
Okay, go for it.
Just quickly, I have a few more just to talk a little bit about our outpatient education, or our education, so
Oh,
let me
right,
just
okay.
quickly run through those, and then I am done.
I'm
So I
sorry.
just want to, it's okay, it's all right, I paused, and so.
I jumped in.
It's okay.
Gotta be careful.
Almost done. On Thursday, July 14th, Dr. Brian Bonner, our orthopedic surgeon, presented information on bone and joint health to the residents of Acacia Creek Retirement Community in Union City, and we had 42 residents that attended. Also on July 14th, Dr. Stephen Zahner, family medicine, presented information on concussion safety to the athletes and families of Fremont football and cheer, and 80 community members attended. On Friday, July 15th, Dr. Stephen Zahner also presented beach and water safety on Facebook Live and YouTube. This presentation was hosted by the Arune Foundation, a nonprofit organization based in Fremont with a mission to increase awareness about beach safety. We had 71 community members that participated in the live event, and since that time, 447 additional people accessed the presentation on one of our social media channels. On Tuesday, July 26th, Dr. Bettina Kirkjohn, obstetrics and gynecology, presented breast cancer screenings, when and why. 79 community members participated in the live event, and since then, 256 additional people accessed the presentation. Then on July 26th, Washington Hospital hosted a community forum on anti-Asian hate. The event featured a panel of speakers and a resource fair with community organizations sharing important information on maintaining safety and health in the Tri-City area. We had 100 community members attended. A video recording of the community forum will be available on Washington's YouTube channel beginning August 12th. On Saturday, July 30th, Washington Hospital hosted a tattoo removal clinic in partnership with Second Chance, and we had 24 individuals who participated that day. On August 3rd, as mentioned, the Peninsula Surgery Center held an open house and ribbon cutting ceremony to celebrate the opening of the center. Peninsula Surgery Center is a joint venture between Washington Hospital Healthcare System, the Outpatient Surgery Center, and physician investors. It was envisioned by Dr. John Dearborn and really is an important extension of our distinguished orthopedic program. We had 60 guests that attended the ribbon cutting. Washington Sports Medicine hosted sports physicals on August 3rd at Irvington School and on August 4th at Newark Memorial High School. Physicals were offered to high school athletes and Fremont football players. The team conducted 166 sports physicals over the 2 days and contributed $3,500 to the sports medicine programs at the two schools. As of Monday, August 8th, a total of 91,516 COVID vaccine doses have been administered to community members at our vaccination clinic. I do want to say on November 3rd, if you remember, we began vaccinating children ages 5 to 11 years old, and as of August 8th, a total of 3,766 vaccinations have been administered to this age group. And then on June 27th, we began vaccinating children ages 6 months to 4 years of age. And as of August 8th, a total of 208 vaccinations have been administered to this group. Just to mention a few of our upcoming community outreach events, on August 10th at 3:30 p.m., Dr. Matthew Tenhold, Oncology, will present intermittent fasting for longevity on Facebook Live and YouTube. On Saturday, August 13th, from 10 a.m. to 2 p.m., Washington will participate in the annual Ohana Health Fair, hosted by Bay Area Community Health Network and Newark Community Center. On Tuesday, August 16th at 3:30, Dr. Sunil Dewan, Dermatology, will present Sun, Beauty, or Beast. All these are on the Facebook Live and YouTube. On Saturday, August 20th, from 10 a.m. to 12 noon, Washington will participate in the Wellness and Health Fair hosted by the annual Festival of India celebration in Fremont. On Tuesday, August 22nd at 6:30 p.m., Anna Mazai, registered dietitian, will present Veggies on the Grill, Make Room for Summer Produce. And then on August 23rd, Elisa Curry, coordinator of rehab clinical programs, will present information on fall prevention and recovery to the residents of Acacia Creek in Union City. We do on Saturday, August 27th, we will be hosting a free skin cancer screening program from 10 to noon at the Nakamura Clinic in Union City. And on August 31st, Maria Nunez, clinical manager of our stroke program, will present information on stroke awareness to the residents of the Masonic Homes retirement community of Union City. On August 30th at 11 a.m., Dr. Christoros, orthopedic surgeon, will present rotator cuff repair, advances in treatment options. And then September 6th at 6:30 p.m., Dr. John Dearborn will present Don't Let Hip Pain Win, updates in hip replacements. And so all of those, again, will be on Facebook Live or YouTube. And then lastly, just want to mention the Washington Hospital Healthcare Foundation will host the 36th Annual Top Hat Gala, and it will be in person on Saturday, October 8th at 6 p.m. And the funds raised will support the purchase of equipment and technology for our new trauma center in the upcoming years. So we're very excited for that. So that is my report. Clearly, we're doing more out in the community now with everything since it is getting longer of the list. So, but we're still presenting on Facebook Live and YouTube too. All right, that is my report. Thank you.
Are you sure? Just kidding. Thank you so much. Well, as I said, unless there's any further discussion, we don't have need for a closed session. So there being no further business, this meeting is adjourned. Thank you all.
Thank you. Have a good evening.
You too.
Have a great week.
Stay safe.
Thank you.